If you and your patients keep getting pulled into those miracle shoulder pain videos, you're not alone. And this framework will help you make sense of it all. After 30 plus years treating patients in nursing homes, hospitals, geriatric clinics, and sports clinics, I've learned the hard way that shoulder injury prevention isn't about magic exercises, it's about having a clear, repeatable physio plan. I'm going to show you the framework that I use in busy clinics when shoulders are grumpy and patients are frustrated. The next time you see a flashy YouTube fix, you'll instantly know where it fits or doesn't fit into your patient's realistic care plan. Most of the time, the problem isn't a weak cuff, it's treating shoulders without a plan. Let's fix that before we jump into some exercises and make shoulder care make sense. Major idea number one, first things first, screen red flags, screen the neck, and simple functional diagnostic categories. One of the biggest mistakes I see physios make, and trust me, I've been guilty of this so many times, is jumping straight into rotator cuff exercises before you even know what you're actually dealing with. You grab your special test handbook and start firing off 15 different tests like you're worried you're going to pass another test. Meanwhile, these whiz-bang tests don't actually change anything about your patient's treatment plan. You're just playing geek nerd detective. Cool, but it's not actually helping your patient. Here's the mindset shift I wish somebody had told me years ago. Your job isn't to name the exact tendon or syndrome. Your real job is to keep your patient safe. Safety first, neck second, diagnostic category third. So, first, rule out red flags. Every patient, every visit, look at them with a skeptical eye. That patient who just doesn't look right, unexplained weight loss, constant night pain, or that odd neuro finding you just can't ignore, if something smells off, chase it down. Better safe than sorry. Second, screen the neck. In my experience, pain usually travels down, so always start by checking the neck active range of motion. If those neck motions reproduce your patient's typical shoulder pain, you may be dealing with a neck problem. Then use the arm squeeze test. Squeeze the bicep, triceps. It tends to create more discomfort with neck issues than with local AC or subacromial tenderness. Finish your neck screen with a quick check of the median nerve tension. Arms at 90, elbows straight, wrists and fingers extended. Ask the patient to side bend left and right. Side bending away often produces that familiar neck radiating pain. Third, once you've had those basics clear, I drop my patient into one of my simplified physio diagnostic categories. Overuse, repeated use, excessive loading, not enough recovery. Traumatic, these classic foosh or gym heavy lift that was just too heavy. Or systemic, something like OA, chronic pain, fibromyalgia. Whichever bucket that patient lands in drives the treatment plan. If you see my other video, you know exactly what I mean. That bit of clarity up front changes everything. It stops you wasting time, burning out, and actually lets you treat the patient faster. Once I started doing this, my patients started recovering faster, flaring up less, and I stopped second guessing myself every 5 minutes. Simple, right? But most of us had to learn this the hard way. Major idea number two, simplify your physio treatment approach to cope with any shoulder patient. All right, we've sorted out my simplified diagnostic categories. Now here's the simplified physio treatment stages. Every patient has a home. Every exercise has a place. Every new bodacious treatment machine can be purchased. Just kidding, most of them are duds, time wasters, but that's a different video topic. Patients don't need your help to rest and do nothing, but they do need your help to know when to rest and what to rest and how to get going. That's stage one. Stage one, pain management. Your goal here is to calm things down without letting the shoulder decondition. Early isometrics are your best friend. Simple weight-bearing moves like pressing your hand on the table wake up the shoulder blade muscles without stressing the joint. Add some gentle motion above and below the joint because, well, whole patient, right? Some people call this cross-training, but for the sore, irritated shoulder, less motion is better. Settle the inflammation first. Don't worry about a stiff shoulder or a frozen shoulder. That's stage two. Stage two, recovery of motion. Restore functional motion, not textbook motion. Don't chase perfect shoulder angles. Most people only need the range to handle real-life tasks. About 120, 140 degrees of elevation for reaching up on the shelf or changing a light bulb. About 110, 120 to get to the top of their head for grooming. And enough behind the back reach for toileting and dressing. And a simple crossbody reach for washing the opposite shoulder. You don't need perfect 180-degree shoulder motion to live a normal life. Focus on functional motion, the range that lets them do the things that they actually care about. And stop chasing textbook numbers that don't improve real-world outcomes. Stage three, strength, balance, mobility. Strength, everyone understands. Balance here means stability. And mobility, well, it's still mobility. So pushing up from a chair or getting off the toilet, that's mobility. Also, this is using a mobility aid. Add pain-free open and closed kinetic chain exercises. Pick exercises based on what they actually need to do in real life. Again, my book has tons of progression ideas. Do all that, but miss this next step, and your progress melts away. Major idea number 3, stability is your patient's best armor for injury prevention. Here's the bit most people mess up, stability. You know that moment when a patient finally moves without guarding? That's stability at work. I used to treat stability like an afterthought. A couple of yellow band external rotations, some I, Ys, and Ts, and I think I've done enough. But that was like putting a Band-Aid on a cracked windshield. A big mistake. Stability isn't accessory fluff, it's the key that holds the whole shebang together. Remember this picture? The shoulder is basically a golf ball sitting on a tee. Without the dynamic stability, those big prime movers, pecs, lats, and delts, will yank that ball right out of the socket and you'll be back in pain, fear, and one very grumpy patient. Here's the bit that finally clicked for me. Stability is your patient's real-life functional treatment. It lets the rotator cuff act as a dynamic ligament, keeps the humeral head centered and in contact, and gives the scapula a solid platform. So here's how you actually use this with your patients. First, match the stability exercise to the diagnostic category. In overuse cases, that's those classic anterior dominant rounded shoulders like Yanda's upper cross syndrome and the thoracic kyphosis head forward patient. You retrain scapular force couples, serratus and lower trap, so that the base stops wobbling. In traumatic cases like the classic Fuchs fracture or dislocations or cuff tears, the passive structures are compromised, so your patient needs neuromuscular control to keep that ball centered. In systemic patients like OA or chronic pain, use isometric stability to keep muscles firing, minimize joint stresses, and yet keep your patient functioning and safe. Second, change the flavor of stability as the patient moves through the treatment stages. In pain management, you use pain-free, closed kinetic chain exercises, simple weight shifts on a table or against the wall. They provide gentle muscle activation that helps calm the nervous system. In recovery of motion, you use closed kinetic chain, but start moving. Still pain-free motion, like table slides or wall angels, because the co-contraction feels safer when the joint is grumpy. Then in the strength, balance, mobility stage, you add load, progress to reactive power, something like countertop push-ups, progressing to wall push-ups, progressing to ball on the wall, rhythmic stabilizations. Now the cuff and scapula have to fire when life actually happens. That's the system, a simple framework, clear stages, stability threaded through it all. And third, never forget the cannon and canoe principle. The shoulder blade needs to move freely but be stable. Exercises like a push-up plus or loaded carries teach it to lock in just enough so that the arm has a solid base to work from. Do this right, you're not just giving patients stronger shoulders, you're handing back their autonomy, the ability to carry groceries, turn a wrench, or hit the gym without that low-level dread in the back of their brain. That's real stability, not band fluff, not textbook perfection, just practical exercises that slot straight into a simple framework that you can use every day. Bonus idea, there's no bulletproof, and that's the good news. I've watched a lot of good physios burn out because they're trying to be miracle workers. They thought their job was to eliminate everyone's pain all the time, prevent every injury, and engineer perfect joints. Physios who last figured something out. They figured out that job isn't to create perfect shoulders, it's to build resilient people. So here's what it looks like in practice. First, you can't prevent every injury, not completely, not forever. You cannot prevent every shoulder flare-up or awkward fall or overloaded bench press. What you can do is reduce the risk and tilt the odds in your patient's favor. Once you genuinely accept that, everything changes. You stop promising bulletproof shoulders and you stop feeling like you failed when someone tweaks something despite doing everything right. You start coaching like a clinician who understands probability instead of pretending that you can control the uncontrollable. Second, start training functionally. You're training the whole system, not just a single joint. Stability isn't just a sad little yellow band external rotation exercise. The shoulder is a force transmitter. Power comes up from the legs. The trunk travels through the arm. If the trunk is shaky or the hips are weak, the cuff is already losing. You can start by band external rotations, but then progress the stability component. Get past those endless I, Ys, and Ts. And yes, we all started there. But start training real coordinated strength, rows, carries, presses, or like a bicep curl that rolls straight into an overhead press. Even a controlled clean and press when it fits. These patterns build a stable scapular base because you can't fire a cannon from a canoe. The shoulder doesn't work in isolation, so stop training it like it does. Let real life drive the plan. If they haul luggage, train hauling. If they reach into high shelves, teach overhead work with control. Third, stop chasing perfection and start chasing independence. Fix the obvious movement faults, but don't waste time debating the ideal scapular position. The real win isn't some perfect mechanics or full 180 degrees of flexion. The real win is, can they carry their groceries, turn a wrench, or sleep through the night? Keep it simple. Progress it properly. Talk to your patient. See what they need to do. Build their capacity. Boring steps beat YouTube gimmicks every time. And if you take nothing else from this, remember, shoulder stability isn't about chasing bulletproof exercises or perfect numbers. It's about following a clear plan, progressing in stages, and building strength, control, and confidence that actually lets your patients move through their life without fear. That's how you ditch the hype and build real resilience with a framework, not a fad. So the next time you see some miracle cure on YouTube, you'll have a better idea where it all fits in. And while you watch your patients doing banded external rotations, you got to ask yourself, am I building capacity, or could we be adding some stability here? If this sharpens things up for you a little bit, that's why I make these videos. Grab your goniometer, let's get going. My 2 books are now available at Amazon. What They Don't Teach You About Documentation in Physiotherapy School, a short how-to manual for successful daily note templates, and From Injury to Recovery Through Exercise, simple functional exercise progressions for physiotherapists to restore lifting, standing, walking. Thank you for your support. Get ready for more sparkle, this video right here, and let that subscribe button be your gateway to a world of endless possibilities. Thank you.